Hi everyone. So exciting to be talking about evaluating mold illness tests. I think it's a really relevant topic at the moment because, especially in Australia, where the diagnosis of mycotoxin and mold spore illness is not part of standard diagnosis. Understanding, I guess, the evidence behind some of these tests is really, really important, especially when we're going ahead and justifying our diagnosis. Hopefully, however, we also will have the results of the biotoxin study through Macquarie University actually implemented throughout standard care, and that's going to make all our lives a lot easier in terms of justifying diagnosis. So, introducing, I don't really need to introduce, but Dr. Sandeep Gupta, who is an integrative doctor in Queensland, and he runs Lotus Holistic. He pretty much brought mold understanding of mold to Australia and has got his courses up as well. Mold Made Simple, and he's also had he's done the shoemaker certification. Yep. And then the other speaker today is Dr. Amy Derksen, and she's a naturopathic physician in Seattle. She's done an undergrad in biochemistry. She's the first physician to do a post-grad training with Dietrich Klinghardt, which is very, very exciting. Some of you guys have done the ART training with Finn. She has a special interest in autism spectrum disorder and chronic illness of all kinds. And she also comes, which is always super useful, from her own personal experience with mold exposure and autoimmunity, which was triggered by mold.
Okay, so today's webinar, actually, let me make this small. Give me 1 second. My apologies. Okay, so today's webinar, we'll talk about basic testing principles. We'll get into urine mycotoxin testing that you have available and the different types and how to make a decision between them. We'll talk about serum testing, so direct testing for mycotoxins, testing for mycotoxin antibodies, and testing for mold antibodies. And then we'll share a little bit about our upcoming course, which we're about to start our second cohort of Mold Illness Mastery, which is an 8-week course for practitioners that we wish we could go back 20 years. It was the course that we would have wanted when we first started working with chronic illness. Okay, next slide, please. So evaluating mold illness tests for Australian practitioners and what you have accessible to you. So to understand the different testing options, so which labs, which tests, and what do they actually test for, and when do you decide to do testing or not? Because it's not always, you don't always jump to testing. There's budget constraints, there's patient interest, there's maybe you're troubleshooting a lot of other things. So we'll get into that a bit, and we definitely do a deep dive in that in our course. The next thing is how to prioritize when it's helpful to test versus not test. So how does it change the management of versus family members' confidence in the treatment, which is a big factor. So this is something I always put into practice is if I'm ordering a test, it's because it's going to change how I'm treating this patient. I'm not just doing it for academic reasons unless I need something to back me up, like this is a disability claim or there's some sort of litigation. So which tests are accessible to Australian doctors? So there's local versus overseas. There's shipping considerations, which Sandeep will get into. Blood versus urine testing and cost to the patient is always a big factor. And then whether the case involves litigation can change the decision making. So if there was a mold exposure at the house that is known about, there's water damage, there's some sort of lawsuit happening, you probably do need as much data as possible to prove that that patient is sick directly from mold. And that still gets incredibly complicated. But we have to demonstrate causative links. Okay, let's go to the next slide. So Australian accessible labs to help diagnose and screen for mold illness, and then to inform and track treatment. And one thing we won't be talking about today so much, but there's also really looking at the clinical picture and how do you use questionnaires to your advantage? How do you really look at symptoms and put that all together? That comes first, and looking at a good history before you get to the point of then collecting tests. The tests are going to be the icing on the cake to really help solidify the theory that you've already come up with. So there's urine mycotoxin testing. So we have 3 labs to choose from. We have real-time labs, which is from Nutripath, we have Mosaic labs, which you can get through RN labs or Australian Biologics,
Yeah.
and you can do Vibrant Labs. And I have a slide coming up that will talk about the differences in those tests, which, when to make that decision. Is this person really a good excreter? Do you think they're a non-excreter? What are you really looking for? Because there are some differences, and there's also differences in whether you would select to do a provoking agent or not. There's serum mycotoxin testing available from Armin Labs. There's serum mycotoxin antibodies from my Mycolab. There's serum mold antibodies from Alites. And there's the chronic inflammatory response
Actually,
syndrome blood
sorry, just real
markers. So,
quick, Amy, do you mind if
yeah.
I forgot to put this in here, but RN Labs also has the IgE serum mold antibody panel, which
Oh,
is
great.
Mosaic. Yeah. So I haven't used it yet, but it exists.
Yep. Okay, good to know. So some of those CIRS blood markers like VIP, copeptin, leptin, VEGF, and a few of those, which in the States I get coverage from insurance. Sandeep, do you get coverage with
You
insurance
you
for those
can
markers
put
there?
them. I think VEGF not, and I think
VEGF.
leptin not. But I think
Okay.
definitely the VIP and copeptin and osmolality and those kind of ones can be put on Medicare. If you're
Yeah.
doing them on every patient, though, it may be recommended to start putting them on non-Medicare forms.
Yeah. Okay, let's go to the next slide.
No.
So urine mycotoxins. Okay, so there's three major clinical controversies in urine mycotoxin testing that we'll talk about next. So exposure versus colonization versus disease. We don't necessarily know when we're looking at the results, what does this indicate? So it's going to be insight of is mold part of the picture for this patient, but it doesn't always answer the question of is this mold exposure that's happening right now, or is this previous exposure that they just either have some sort of colonization and they continue to be sick from that, or there's some other old issue that they're carrying and it's stored in their tissues. So current testing can't reliably distinguish between exposure and disease. So the clinical context is incredibly essential. And when you're getting into mold illness and even identifying mold illness in the first place, your clinical case, a good note taking, and a good history is going to pave the way that you're on the right track. So do not shortchange what you do with all of those survey tests. So when we're looking at exposures, so it can reflect recent dietary exposure like coffee, wine, they ate a bunch of peanuts, or environmental exposure, something in their current home environment. Colonization. So think of, mold loves warm, wet places, right? The sinuses, the gut, the lungs. So is there colonization happening somewhere? And is there actually just disease? So positive result means excreted mycotoxins, not necessarily active illness. So that's where we get into some of the other testing. Let's go to the next slide. So the other controversy is do you provoke or not provoke? So non-provocation represents the baseline first morning excretion rate by that patient. Provocation means we've done something like glutathione or sauna or given binders, or we have them exercise to mobilize those toxins. Something I use a lot in practice is astaxanthin because it also helps with urinary excretion because I'm really trying to find the most possible. But do keep in mind if you want to compare apples to apples. So if you're starting with one test on a patient and then you're trying to follow up with them later, recall if you actually did provocation or not so that you're doing the same test as a repeat. So the controversy with this is there's no standardized protocols and you can produce very high results that are difficult to interpret depending on what your provocation method is. So I would just say be consistent so that you
Mm.
know for that particular test what you're looking for.
And isn't it in general no binders because we're trying to, for a couple of days, because we're trying to not push the toxins down the fecal route. We're
Yeah,
trying to, yeah,
typically.
yeah,
Yeah, we
but
want it
maybe,
coming out in the urine.
yeah, yep. Okay, cool, cool.
Give me one second. I'm sorry. I have a funny thing here. Band is coming up there. Okay. So clinical validation and reference ranges. So mainstream medicine concerns here, dietary exposure in healthy individuals. There's limited population studies. The results are not interchangeable between labs. And this can be a problem. But integrative utility, however, the testing is useful when interpreted alongside environmental history, symptom clusters, and CIRS inflammatory markers. So you're trying to paint the entire picture. The mycotoxin test alone, I would say, is not a standalone test to give you your concrete diagnosis. It is painting part of the full picture. Let's go to the next slide. So your clinical takeaway for practitioners is diagnosis should integrate exposure history, your clinical symptoms, environmental testing, inflammatory markers like C4A, MSH, VIP, treatment response. And this is a big one. If you put someone on treatment for mold illness and they get better, you have some confirmation that you're on the right track as well. And then looking at treatment history, one of the best things you can ask, I tend to be a last stop for people, right? So they've already been to 20 doctors before they find me, is I want to know, of all the things that you've tried, what are the top three things that have helped you, if there are three things that have helped you? And what are the things that have made things dramatically worse? Because that already gives you a lot of insight. Like maybe they can't handle methyl donors, or maybe they're incredibly sensitive and, they tell their story of like anytime you do even a tiny bit of something that they get worse, then maybe this is a mast cell issue that's triggered from this. So it'll give you a lot of insight as far as treatment. So the best way to interpret this is it's evidence of a toxin exposure and excretion rather than proof of disease, but it does really help paint the picture for you. Okay, let's go to the next slide. So urine mycotoxin testing, let's talk about the methodology differences comparing mosaic, real-time, and vibrant. So let's go to the next slide. So the main two differences are going to be, if we're looking at mosaic and vibrant, these are going to be a different methodology than the real-time lab, which is ELISA testing. So the mosaic and vibrant is going to be measuring free mycotoxins. So practically to show up on this test, the patient has to be actively releasing and excreting the unmodified toxin. So poor excretors might show false negatives unless they're pretreated with glutathione or sweating protocols. But some of the controversy is that actually if you give glutathione, especially with the mosaic test, that can interfere with the results. So they really kind of shy away from doing glutathione. So typically something like exercise or sweating or taking fairly high doses for a few days of astaxanthin can help as your provoking agent. But if your patient is incredibly sick and they're just not excreting, I've had some of my sickest patients have a urine mycotoxin test with either vibrant, but especially with mosaic, where nothing shows up at all. But then when we do some of the other tests that Sandeep will talk about, we'll see some of those antibody levels being quite high. So I know that patient is really stuck, and their main issue is they're not excreting. Their body does not, it's just constantly accumulating these mycotoxins and not able to get them out, which is why they're continuing to get more and more sick. So the real-time test using ELISA is a bit more practical because it's measuring conjugated and bound mycotoxins. So it uses antibody testing to recognize the toxin structure, even if it's bound up to detox carriers. And so it's capturing toxins in patients whose bodies have conjugated the threat, but haven't fully cleared it. And this can be a little more useful in some of our very, very sensitive patients that we just think are not excreting at all, or the ones who get really bad, anytime we give a little bit of liver support or lymph support, sometimes starting with a real-time test can be a little bit better. And there isn't the interference, I would just say, on the real-time test. You can definitely use glutathione as a provoking agent for that one. So the detection technology, direct measurements versus antibody binding. So with mosaic and vibrant, it's using liquid chromatography, tandem mass spectrometry, say that 3 times fast. It's direct molecular identification based on the exact mass to charge ratio of the mycotoxin molecule. So it's a direct measure. With real time, it's an enzyme linked immunosorbent assay. So it's an indirect identification using polyclonal antibodies designed to recognize and bind to the structural epitopes and mycotoxins. So that can be good for your non-excreter. So the clinical summary, how to select the right lab. So if we were to look at the technology, so similar technology with both mosaic and vibrant, ELISA technology with real time. When we look at the number of markers, so mosaic looks at 11 markers, where real time will look at 16 markers, and vibrant's going to look up to 31 markers, so looking for a broader array. So Mosaic and Vibrant are both looking at the free mycotoxins, where real time is looking at the free and the conjugated or bound up toxins. And the ideal patient. So for Mosaic, this is classic presentation, someone who needs highly specific, unassailable validation of common pathogenic molds to justify those aggressive environmental remediation or treatment strategies that are going to cost them money. And we need that support that we're on the right track because maybe our patients burn out. You know, if they found you and they've already been to multiple doctors, sometimes it takes some convincing to get them on a new treatment strategy because they've given up quite a bit of hope. When we look at real time, this is really good for the poor excretor. So this is that highly sensitive patient that really struggles to detox, where the toxins are bound and trapped, and we're really suspecting that they're there, but we just can't typically see them. And then the Vibrant Lab is really good for the mystery illness because it tests so many markers. It's going to look at that complex refractory patients that require a very broad net. So we're like casting a broad net just to see what we can catch and find. Okay, so which mycotoxins are linked to which molds? So this is the simplified version. So ochratoxins are mainly Aspergillus. Aflatoxin is mainly Aspergillus. The trichothecenes are Stachybotrys or Fusarium. The zearalenone are Fusarium, and the gliotoxins are Aspergillus or Candida. So that's always one to pay attention to.
100%. And I'll just jump in and say I've really become very aware of, if someone has very high zearalenone, that they're very much at risk of moving in a cancer direction. So for
Mm.
women, particularly breast cancer, and for men, it would be more prostate. So just, the awareness of that one and how estrogenic it is and mutagenic. So just thought I'd jump in with that.
Yeah, and one thing that we won't get into in this class today, but with the particular mycotoxins, so one of the advantages as a clinician of having the different mycotoxins measured is there have been a lot of studies showing which binders are best for which mycotoxin, right? So if you can narrow down what you're dealing with, then you can better direct your care for your patient to know, okay, what binder do they need help with to get this out of the body? So here's an example of the Mosaic mycotox test. So it's a urine test, which, is the nice thing with all of these, right? They're urine tests that can be collected at home. For those of you who do telemedicine, this is great because you can just send the kit to the patient. So as you can see here, anything that's showing up over in that high red area is definitely something to catch your attention. So we've got ochratoxin, the Riordan, we have basically some aspergillus markers showing up here. Some gliotoxin, not as bad as the others. And then MPA or the mycophenolic acid. There's a teeny bit of controversy on this one. So Jill Krista was referring to the MPA as mold farts, right? Not to be crude with that, but just the thought was that maybe it could be a marker of active excretion from living mold. So a little more evidence of current exposure. There is a little controversy to this. A newer article came out and it was questioning that. But I would say clinically, the MPA always catches my attention. If that one is elevated, then I am more suspicious that I need to really investigate the home environment or possibly even look for colonization that's actively going on. Do you have any other comments on this one, Sandeep?
Yeah, so I'm more worried when I see the trichothecenes such as Roridin E and Verrucarin and so on. I am more thinking that it's likely there's an environmental source,
Right.
if not now, in the past. So, of course, one of the classic things is they've been in a water damaged home and now they're carrying it in their body, and so they've now got the water damaged building in their body.
Hmm.
So that's a possibility as well. And yeah, anything above around 8 on the ochratoxin is definitely, so this is way over. So there's
Yeah.
definitely some source here. I think this would be very unlikely to just be a coincidental exposure kind of thing, which you always think can
Yeah.
always think about if someone's got a really borderline result. Let's say they're just on the borderline of the green and the red here. You might think, okay, have they just had an incidental exposure? But this is way above that.
Yeah. If you saw these results, for me, if I saw these results, there's no question that there's
Yeah.
a mold issue happening. I mean, I live in a very damp area, and so there's going to be a lot of incidental mold exposures, but we're not going to see levels like this. And typically not even enough just from typical environmental exposures, just from living in an area that's more damp that would even go into the red range.
Yeah, I tend to think that like you should see a tiny little bit of ochratoxin A
Hmm.
on almost any test, and if you see zero, for me that's also also suggestive they've got a mold problem.
Yeah.
Because most people have a little bit of exposure, so somewhere around that 1 to 2 range, I would say is
Yeah.
actually more reassuring than abnormal.
Yeah, I would agree with that. That patient, when I was working her up for mold, that I was very alarmed with, had zero on everything. And so we ran it then on her husband as well, who then did have some elevated markers because I was just trying to see, okay, is there something in the home? And then when they did investigation, they found a huge mold issue in their house. She was just a non-excreter. So I agree with that, that ochratoxin being an aspergillus marker, everyone should be exposed to a little bit. We should see something,
Oh, and
right?
Dr.
So,
Rabinoff, who's here, Amy, he presented a case where there was one patient who had elevated mycotoxins and there was no environmental source, and they found out conclusively that it was food. So I guess
wow.
it can happen, although it's not common.
And they had elevations in multiple markers.
Yeah. Do you want to unmute yourself, Rome? I know you're muted.
That's correct. I repeated the testing.
Yeah,
Wow.
yeah, he presented it. It was
Yeah, and,
You would think it would be environmental, but in this case, it ended up being
yeah,
food.
Were they
and the
were they
and
eating an
the
unusual diet?
packaged food was a common packaged nuts and packaged grains. When they
Wow.
got rid of those, they settled down. And I also sent to Germany to double check to a laboratory there. They picked up the same, and they could pick up the actual fungi.
Huh.
And
Wow.
from the fungi, you could do a search to find out the cause, and it was mold from food.
Interesting. Hmm.
Yeah. So yeah, that was a really interesting case that raised my awareness to the possibility, but it
Yeah.
still seems to be much rarer.
Yeah. So we
Yeah,
typically in my clinic we do a fairly clean diet. So we have just an instruction sheet that we give out to people of foods we want them to avoid for the 3 days before testing, just to eliminate at least some of the obvious triggers of that. But wow,
Yeah.
that's interesting.
Yeah.
yeah.
Okay,
The
so
only
here's
problem that way is by doing that, you might miss the person where it is coming from food.
right.
Because your patient was actually unwell as well. It wasn't
Oh,
just,
yes,
yeah, he was unwell from
Yeah,
the food as
and
well.
came good. Yes.
Yeah. Yeah.
right.
That's a thought.
Yeah, and they probably had, my guess is they probably had some pretty significant leaky gut that would make them more vulnerable to that.
Uh,
That's a thought.
yes, not too bad, but they did have gut symptoms.
Yeah. Hmm. Interesting.
Thanks, man.
Be an interesting case to follow up on.
Yeah.
Okay, so here's some more examples from the mosaic mycotoxin test. So this one, you can see the aflatoxin looks normal there. The ochratoxin quite high on this one. The trichothecenes that we had looked at. So this is another view of what we just saw. But those trichothecenes are often stachybotrys or some of the, the stickier black mold, which, like Sandeep was saying, is typically more evidence that there is an issue going on at home or that there was a very significant issue at home because we just wouldn't be exposed to that typically if we weren't around it quite often. Okay, let's go next slide. Okay, so here's some other ones that it screened for. Again, this is just, it was the summary sheet in the first one that showed up. So as you can see here, like most of these are relatively low. That MPA is catching my attention. It's not crazy, but there might be an active thing. But if we had already seen those trichothecenes showing up, that we already know that there's an issue or suspicious of an issue. Okay, now this is looking at the real-time test. So this is that different methodology, again, better for that more sensitive patient who maybe isn't the best excreter. So ochratoxin, it's showing that it's present here. You can see, so it takes getting used to looking at whatever labs you're going to use to. Typically, you can provoke this if you want to with glutathione. It won't interfere with the test results. Aflatoxin here was showing up equivocal. So as a standalone, it wouldn't necessarily be enough evidence, but typically we're looking at the full array. And then let's go to the next slide to see how everything else showed up. Those trichothecenes were present in this one. So those were elevated. And in my experience, if the trichothecenes are elevated, you have to pay attention because that is a marker of Stachybotrys, which really just shouldn't be there. It's black mold. It's behind the drywall. It just that's usually a long-standing exposure. It's just not going to show up. That's not coming from food.
Mm,
That's not coming from other things typically, unless it was really contaminated sources. The
right.
gliotoxin's present here, and the zearalenone is also elevated. So we know that this person has an issue, whether it's from food or from their environment. But we know we have some work to do.
That's right. And some studies, I believe, showed that using NAC and Saccharomyces may be useful in gliotoxin cases. Is that right, Amy?
Yeah,
Yeah, so that can
yeah,
be useful.
definitely.
And then often I would think about something like DIM, diindol methane, if they're showing up zearalenone. Because even if
Yeah,
their estrogen levels would be showing up reasonably normal, you can know that their estrogen receptor is getting stimulated by all this zearalenone.
yeah. And I find that most of my chronic patients do really well with DIM, even some of my teenage boys. It upregulates that phase two liver detox, especially related to some of those hormones. So it tends to be really well tolerated. And you don't have to use a ton. Sometimes just a capsule a day is plenty. Quicksilver makes a nice liposomal. I don't know if you have access to that, but typically the capsule
Yeah,
forms are
I
fine.
think FX
As
Med, yeah, we can get it through FX Med, I believe.
Oh, great. Yeah. But especially if there's anything unusual hormonal, or if you're doing hormone replacement therapy, do consider using DIM because it will help with how it's metabolized.
Great, thanks.
All right. I'm going to hand off to you, Sandeep.
Thank you. So that's really interesting stuff. Thanks, Amy, on the urinary mycotoxin test. And it really is it's an evolving science, and I think we're learning more and more. Even just like Graham's study, I think we should probably bring that into the general awareness with people like Neil Nathan and Jill Christa. They probably be really interested to see that. Actually, I'm just
Mm.
realizing. And
Yeah.
yeah, just the worldwide think tank who are looking at these tests. But overall, it seems that that in general, it's decent at differentiating between environmental and food exposure, with a rare exception. So now we're going to jump onto serum testing. So serum mycotoxins. Serum mycotoxin antibodies and serum mold antibodies. So guess I've been looking into these in quite a lot of depth for the last 6 or 12 months, and it's kind of, again, it's an evolving area, and here are a few of my thoughts, or our thoughts, on these. So this is the first one, is Almond Labs in Germany. So my understanding is it's mainly WA and Adelaide who can reliably get blood to Almond Labs, according to Dr. Durham. And for the East Coast, like certainly for Brisbane, we found that every sample we sent there would not get there in time. So it's not really an option for some of us. Well, certainly Brisbane. Maybe Sydney and Melbourne is better. So what they're looking at is the actual levels of mycotoxins in the serum, and so in this one they did actually pick up a small amount of the deoxynivalenol and ochratoxin. However, they weren't above the reference range. So the couple that I've sent have both been totally negative. However, it may be that the issue is that their reference ranges are set a little bit high, and that we do need to take note of even minor elevations. That would be my thought.
Mhm.
Otherwise, it seems to be a little bit insensitive, is the feedback so far. So, looking in general here out at the difference between some of the main serum mycotoxin and antibodies. So Almond Lab is just looking at the mycotoxins, while Alates, which is a new lab I've started using, which is in the east coast of the United States, and My Myco Lab, which I believe is located in Florida, are looking at the immune response to mold and mycotoxin. Sorry. So Alates is the mold, My Myco Lab is the mycotoxins. So Almond Labs is just looking at the mycotoxins, while Alites and MyMycoLab are looking at mold and mycotoxin related antigens. So the Almond Labs would relate to the internal toxin burden of mycotoxins, while Alites and MyMycoLab are more relating to mold exposure, current mold exposure. So it can be the Almond Labs may be current exposure, or it can just be circulating mycotoxins from the past. And again, with Alites and MyMycoLab, it's past and current exposure, but the studies, which I'll get into in a moment, seem to indicate that they are quite well correlated with current exposure. So immune involvement. So the Almond Labs isn't really looking at any kind of immune response. It's just looking at how much of the toxin is there. While the Allotest and the MyMyco lab are looking at direct immune responses. So the use might be in cases that the Almond Labs may help us to understand the total load of mycotoxins. While with Allotest or MyMyco lab, that can tell us, I guess it's a little bit about sensitive. There is a little component of that, but it's really more to do with exposure, is what the studies are saying. So we'll come back to that in a sec. So jumping into my myco lab testing. So I'll jump onto what the results look like. This is an example. So this is the IgG result, and that's an IgE result. So they're not exactly, they don't exactly always mirror each other in the same patient. So it's possible to get a high IgG but a low IgE, and vice versa. So if you see an Ig dominant patient, that may mean they're more getting exposed to mycotoxins, and they may be a significant mast cell or histamine focus. So you're not thinking as much of colonization in those patients. While if it's IgG dominant, you're thinking, okay, the patient's got colonization in the body, so they may have chronic fatigue and brain fog and may need treatment for colonization. So I recently had a patient who's had basically exposure in a police station in Brisbane. And so I've seen a lot of problems with police stations and public schools.
Yeah.
Major issues. So we actually had one patient who got cancer in this Brisbane police station, and actually was acknowledged by the government as being caused by mold, and the family got a payout. So that's very interesting. So it was the same police station, and the patient has taken a lot of binders for mycotoxins, but we just repeated the test, and it's still showing very high IgG. So that tends to indicate there's a reservoir of colonization somewhere. Now, if you're getting both of them low, but they're symptomatic, you might think about immune suppression. So you might want to check their total IgG and total IgE, even though Dr. Campbell doesn't believe, who's the lab director, doesn't believe there's a correlation. Secondly, it could be what Dr. Shoemaker described as poor antigen presentation, because in his model, it was that no antibodies are produced when basically someone is not able to carry out antigen presentation, which is his original HLA hypothesis. And it may be that there's a high toxin burden but poor immune recognition, which I guess is the same concept. So yeah, so the clinical pearl is IgG is more correlated with mycotoxin exposure, and IgG is correlated more with colonization. This is more word of mouth with colleagues who now work for my myco lab. And according to the study, which we'll talk about in a moment, IgG correlates most with exposure and is most predictive of mold illness.
Mm.
Okay, so this is a IgG result. So basically, we're saying prior or ongoing exposure, and this particular patient, and this was your patient, was it, Amy? Still
No,
struggled.
this was your patient. I think
Okay.
this was yours. Yeah.
Okay. The patient still struggled to be. Oh, I know who this is. Yeah.
Yeah.
Yeah. So
Uh,
sometimes, so that's where sometimes these tests can be useful. Is if, let's say, the patient or client themselves is really resistant to the explanation that mold is causing symptoms. Well, when they see this come up in red, Maybe it's not great for their limbic system, but certainly it's pretty in their face um,
Yeah.
about about the effect that mold is having on them. So yeah, so it can be like chronic inflammatory states. Well, I said colonization according to Dr. Tessier, who's the naturopath who works for my micro lab. And the symptoms we may see: fatigue, brain fog, chronic illness, less immediate reactivity. Yeah, I think that's probably true. More persistent dysfunction. So it may not be as much of a mast cell phenotype, and it may be more like, I think the classic thing I would look for is, are they really congested in the nasal passages, or do they have that classic, a classic mold cough would be like someone who does that dry cough all the way through the patient interview. You start to nod your head, so you nod your head and go, yeah, I see
Mhm.
what's going on here. They're just doing this little dry cough, and of course there's a crossover with asthma. Sometimes it can be diagnosed as asthma, but sometimes it's not. It's just the cough, and that's the lung colonization. So then this is the IgE. So this suggests that the immune system sees the mycotoxin as an allergen, and it's triggering a type 1 hypersensitivity reaction. So more consistent with a mast cell activation or histamine-driven phenotype. And so sinus congestion, perhaps, I would say more like a runny nose, itching, rashes, wheezing, head pressure, and immediate symptom flares in mold environment. I think that sounds right. So it's not so much that they've got the water damage building in their own body, but more that they're reacting to the external water damage building and fairly immediately. So that can be a correlation. So then moving over to Alates, I don't know how many of you have used it, but it's something that I was turned onto through the ICI forums, and Dr. Pejman Katarai, his name is. He's a pediatrician in the United States. And basically, they have a number of different panels. But one thing is the price is about half the price of urinary mycotoxin testing. So generally, you can do a mold immunoreactivity panel, 6 IgE, 7 IgG, and 7 IgA, or expanded immunoreactivity panel where you've got a lot more IgEs and IgGs. Or the one I use is just the 15 mold IgG panel. So it costs roughly 250, including postage. And it's generally not one that you repeat regularly, by the way. We didn't talk about that, but in general, with the mycotoxin testing, we're usually recommending to repeat it around about every 9 months, looking for a pattern of reduction. While with this test, it's not as reliable that you'll see the antibodies disappear with treatment. So it's not necessarily one we'd recommend repeating. It might be one you just do at the start. So, what does it mean? So, firstly, IgE antibodies to mold, and this is, well, I guess you could say that's a test that's commonly done by immunologists and allergists in Australia, and it was found to correlate with a blocked or runny nose and rhinitis in this Finnish study from 2000. So those are kind of more classic allergic symptoms. So there is a correlation there. While the MyMyco lab, it's not as clear. But they found in the 2003 study by Voidani and Campbell that only IgG to Aspergillus was higher than the control group significantly. The other ones were not significantly different. So I don't believe it's as useful a marker, the IgE. And so I don't use it. Unless it's, I guess, unless someone's got more of a classic allergic profile, then you might. And I'd probably just tend to use RN labs rather than ALA and use the mosaic testing. So the IgG, on the other hand, was found to correlate very directly with symptom patterns in the families tested in the 2000 study. I'll get onto this at the moment. In this study, there was two groups. 80% of them were families with their home environments, and 20% were occupationally exposed people. So the weird thing was they didn't find any correlation in the occupational cohort, but they did in the families. So I haven't quite unpacked that one as yet. But it may well be that there's certain molds where it's not as predictive. And again, it was significantly higher than the control group, and the p value was less than 0.01 in the 2003 study, which is the Voidani and Campbell one, which we'll go into in a moment. And then IgA, which we generally think of more as being mucosal immunity, right? Well, they were found to be significantly higher than the control group, p less than 0.01. And I think it was just there was a slightly lesser number of molds which were predictive in the Voidani study, and also correlated with positive intradermal skin tests in a 2018 study by William Ray. So it does appear on the balance that they do have a clinical meaning. I will also mention that there are some negative studies, which is probably why the Finnish group, who were studying dampness and mold hypersensitivity syndrome, who originally were going to use mold antibodies as their primary biomarker, ended up dropping it as their biomarker. But when you look closely at those studies, I think the issue is in some of them, the control group also had mold in it, and they weren't testing it rigorously enough, and therefore there wasn't significant differences between the cases and the controls. So this is how the results look to the 15 IgG antibody panel. So you can see that you got 3 or 4 plus in quite a lot of these different molds, including Cladosporium, Aspergillus. It also includes Candida, so that's not a mold, that's a yeast. So that can also give additional information. And then this is the IgE panel. And they basically looked at it. They look at a mix firstly, and they came up with a negative, and then they look at more specific species, and this one also showed a negative. So this is again looking at a IgG panel. This is where you're doing an expanded, I think this is one of the immunoreactivity panels where you're doing some IgG, some IgA, and some IgG. And you can see that in this case, they're showing up very high values for IgG, but not at all for IgA. So at this point, we don't know what that means. But it could be that they've got an IgA deficiency, could be one explanation. Or it could be that there's no gut colonization. That could be an area for research. That would be a possibility, wouldn't it, Amy?
Yeah, that would be a possibility.
Yeah, if we're thinking
Yeah.
IgA is more gut mucosal immunity.
Yeah, and IgA levels, I typically would just do a blood test and also do, it's measured a lot in stool testing just to get an idea
Yeah,
if the
the
IgA levels are low.
secretory IgA. Yeah,
Yeah.
yeah, yeah. So that would be interesting. So then you would think, so if someone had like low secretory IgA, would we expect that they may have a low, total
Hmm.
IgA to mold? It could be. Heather's nodding her
Possibly.
head, so we'll go
Yeah.
with that.
Yeah.
Okay, so just a quick literature review here. So this is the USA study, which was done in 2003, which was by Aristo Vodani and also others, including Andrew Campbell, who's the director of my Myco lab. So what I've done in red here is just circled, or sorry, or outlined those molds which were statistically different between cases and controls. And you can see for quite a lot of this, like if you look at penicillium here, well, it's actually 4 times higher in patients than controls. And epicoccum was about 3 times higher. Trichothecenes were 2 times higher. So it is very significant in this study, uh, the difference between cases and control. However, there were some overlap, and they did mention that. And the authors said this basically represents the fact that there's a bunch of people who aren't symptomatic who are getting exposed to mold and they just don't realize it. So it's more that, so what it's not as good at differentiating is people who are being exposed to mold and those who are symptomatic due to mold. So that you have to tease out yourself. But it definitely correlates with the levels of exposure. Now, IgA was also good, except epicoccum, which is not really considered to be one of the most important molds. So I don't think that's a big deal. With all of the other eight, it did show a significant difference between cases and controls. Now, IgM only showed six of the nine as being statistically significant. But you can see some of them, like the trichothecene, there was a factor of 4 times difference here. So average of 5 for controls and an average of 20 for patients. So it may be good for certain molds and not others. And maybe, yeah, maybe Andrew should have looked at IgM mycotoxins, because also the other mycotoxin they looked at, saprotoxin, that was also a difference by a factor of 3. But IgE was only useful for one mold, which is Aspergillus, and one mycotoxin, which was saprotoxin. Actually, it's surprising that this one, the trichothecene, didn't show up as statistically significant
Yeah.
because it's more than double. But it may have been a low sample number. So I think you see there, overall, it does give a good level of correlation between cases and controls, the antibodies to mold and mycotoxins. So the number of patients was 80, and there was a control group. And this is how they represented it graphically. And so the control subjects were kind of this, the hollow diamond like that. And the patients were the filled in diamond shape. So you can see here, like this particular patient here was higher than many of the patients. But in general, there is a significant difference. And like the highest ones in the patient group were certainly unmatched in the control group. And some of them appear to be more correlated than others. In this cladosporium group, you can see there's a whole range of results in the patient group that are much higher than the control. So that one seems even more predictive. Uh, but overall, there is a tendency towards difference, but you can't 100% say that someone with elevated mold antibodies is symptomatic because of mold exposure, but you can say that it's likely they've got high mold exposure in the background. But whether or not the symptoms are correlated, that's where your history and everything comes in. So this is the IgA. So a similar pattern. So I think it was the epicoccum didn't show statistical significance. But look, you can see this one here, Stachybotrys. That's got huge significance. That's some of the levels that were reached on the IgA were very high compared to controls. So I think that may even be better for Stachybotrys is the IgA. And the most ideal thing would be like if one of these labs came up with a more customized panel based on the results of the study. Like maybe it's IgG to many of them, and then IgA to Stachybotrys, and then IgM to the mycotoxins, because you can see here with the IgM to saprotoxin, that seems to be very significant, the difference, and perhaps more predictive than the IgM. So than the IgG rather, sorry. So those are all useful. While the IgE, you can see there's a big mix here. The controls were, in some cases, the controls were just as high as the patients. So the IgE is not very predictive in a general cohort, except for Aspergillus and saprotoxin. So, so this next study was again by the same authors that same year, but that looked at saliva secretory IgA antibodies against molds and mycotoxins. And this actually was highly correlated again in almost all molds. So again, it was the same group, I believe. They then just used a different test. And I think what they've done here is superimposed the results from that other study and just put in the white box and the gray box as being the cases and the controls. But you can see in every case there was a statistically significant difference between cases and controls looking at salivary IgA antibodies. So I think that could be quite a useful test too, because it'd be quite non-invasive, that a patient could just produce a saliva sample and it should be able to be run quite quickly. So I think that would be great. Now, this was the other study I wanted to talk about, which was from the Finnish group who developed the dampness and mold hypersensitivity syndrome. Yeah, DMHS. And they looked at serum IgG and IgE antibodies against mold-derived antigens in patients with symptoms of hypersensitivity. So often it was patients who also have multiple chemical sensitivity as well as mold-related reactivity. And what they found, so this is the first symptomatic family. You can see in general the results are probably around 1.5 would be the average, while in the second mold exposed family, well, you can see in this one the children were less affected
Mhm.
than the parents. And but in many cases they're around that 1.5 mark, while this was a non-symptomatic family. And you can see in general their results are significantly lower. They're probably more around the one. So they did find that in those families with exposure at home, there was a significant difference between the IgG antibodies uh, between the two groups. But this is then looking at the symptoms. Overall, there was not a very significant difference. I mean, it's kind of all over the place if you look at this. So basically, they're looking at the 1 to 4 means the level of IgG antibodies. So 1 meant almost zero IgG antibodies, while 4 meant very high levels. So it does look like for blocked or runny nose and rhinitis,
Mhm.
there is a significant difference. But many of the other ones you can see they're all over the place. There's no real significant correlation. Or maybe there's lower levels of some of them. Lower levels of phlegm in the patients with high IgG. So explain that one. Uh so so basically I think the summary is it doesn't predict symptoms. It predicts exposure. And so through our own history, we need to work out if their symptoms are related to their mold exposure. And one of the biggest things for that is asking patients questions around, did their symptoms improve when they left a water damaged building? Do their symptoms improve when they went interstate for a little while? And was there a good correlation of the start of their symptoms with the exposure to a building and such like things? Anything else on that you would think of, Amy?
No, I think you covered it.
Okay, cool. Um, so yet another table. Um, pros and cons here. So yeah, so urinary mycotoxins, I think Amy covered it really well. Basically, it's quite convenient. So
Mhm.
one example is I have one patient who's bedbound and also, so much anxiety that she can't even let a blood collector into her house in Victoria. So I think for her, it's got to be the urinary mycotoxins. But if we had salivary mold antibodies, we could have done that. But all of these are out because of her inability to go and have blood taken.
Yeah.
So, yeah, in that case, probably it would be real times if she's a very sensitive case, you said.
Mhm.
And
Yeah.
what they did, which Amy basically warned against, is their first test they did without provocation, and their second test they did with provocation. See, that's not the way to do it because then you can't really say if a level has gone up, is that
Right.
due to the provocation or is it due to your actual levels going up?
What you
So
can do though with that, because I've done that before intentionally, if the first round had almost nothing coming out, and then we did provocation and did a second round, especially if the provocation was going to be the treatment I planned to put them on. I would
I
get them
see,
in
I
that
see.
treatment protocol, hopefully get them starting to feel a little bit better that they actually we could push some detox because typically the non-excretors, if you do some sauna with them or you do a little glutathione, they feel terrible, right? Or they feel good for a few hours or a few days and then they feel terrible. So it can be good to see are they actually releasing if you do provocation. That would be the only time I would ever do the two, but I tried
Yeah.
to keep the same test, yes.
Yeah. I think it's a great point. So I think having good info sheets that you give to patients explaining exactly what you want them to do is very important, because what you don't want to do is, like, the first time they're eating a heap of nuts and the second time they're not, or whatever, or the first time they're doing a bunch of saunas, the second time they're not.
Mhm.
First time they were taking binders. Well, it's going to be all over the place. It's going to be impossible to interpret. So I think you want to have clear instructions that they follow every time. Do you agree, Amy?
I would agree. And you've got to consider if you're suspecting mold illness in someone, they probably have a lot of brain fog as well. So you want to be very simplistic in those
Yeah.
instructions and very consistent, right?
Yeah.
So there's a clear message. If they have questions, your staff can answer those questions very easily.
No. 2 minute sales pitch here, just to let you guys know about the practitioner course that Amy and I put together. It's called Mold Illness Mastery. We had about 35 people run the first cohort, so it's actually a live hybrid course. So basically, when you join, you get allocated to a specific cohort. So this next one will be the July to September cohort. But you can also watch the lectures in your own time. We've generally found that the people who watch it live are much more likely to complete the course. So I think it's good to attend the live lectures. They're at 8 a.m. Tuesday morning for this cohort. So it covers screening, testing, treatment, management of mold illness, and all the different models, including CIRS, cell danger response, MCAS, colonization, etc. Also, Amy's a bit of an expert at peptides, so she's got a lesson on that. We also talk about mold inspection and remediation. We also do talk about cancer and longevity aspects of working with mold patients long term. So I think there's definitely some new information that many other authors haven't gone into. So Ashley, I hope you don't mind that we're quoting you here. Ashley was part of the initial cohort, and he said the course is detailed, informative, and relative to any integrative GP, and says
We'll
it
read
had
it
many.
back in 15 minutes. Okay, fine.
And then Scott Forsgren, the Better Health guy, said it was excellent and huge value for the investment of time and money. Every practitioner working with mold needs to take this course, so that's high praise from him. So anyway, I think it's worth doing. If you guys are wanting to dive deeper, we're not necessarily saying we have the ultimate truth, but we're basically kind of diving deep into this whole topic and hopefully getting closer to
But
ultimate truth, even if that even exists.
and also how to take that patient who's come to your practice that isn't necessarily saying, "Oh, I have a mold issue." They're saying, "Hey, I don't feel well and I've failed all these other treatments." It's how does this fit in? So how do you even identify it in the first place that you should be thinking about it? And how do you use things even like stool
Oh,
testing and organic acid testing? How do you treat cell danger response and methylation and mitochondrial issues? So it will apply to your other patients, but it's meant to be really practical of how